severe. And then Ajay and I are both parents to newborns, and so we are tired. And those are our personal disclosures. This is my newest kid, Jackson, who's falling asleep listening to Ria talk about ultrasound physics, which is my reminder to ask Ria to come to my house and talk about ultrasound physics at night so he finally sleeps. Just a quick word. So as I mentioned, the three of us are actually from the Society of Hospital Medicine POCUS special interest groups. Ajay and I are some of the co-chairs, and then Ria is one of our executive council members. And so we put on webinars monthly or so, and we're going to have some future mentorship opportunities. So at the end, I'll talk about how you can join us over there if you want to get even more POCUS content. We welcome both pediatrics and adult medicine. So these are our objectives today, kind of two parts. First, we're going to go through some of the most common protocols for bladder and GU POCUS and talk about how you can use this to your advantage as a diagnostic tool in hospitalized patients. And then Ria and I are going to both talk about some different cases as a way to describe how POCUS can enhance your differential diagnosis and expedite treatments of some common conditions. So with that, I am going to hand it over to Ajay, who's going to talk about normal images and protocol.
Thanks, Erin. So just to kind of set the stage, we can all have the same language speaking for as we go forward, so everyone can understand the same things. We'll go to the next slide, Erin. We'll first talk about probes. There's three main probe types: the linear, the curvilinear, and the phased array. And for all the abdominal scans, we're going to try focus on using the curvilinear probe, which is the middle one there. Next slide. Next, we're going to talk about some motions that are common with common terminology in POCUS. So there's sliding, tilting, rotating, and rocking. Sliding is as it sounds. You move the probe along the skin in any plane in the short axis or long axis. Tilting means tilting the probe along the short axis back and forth. Rotating is clockwise and counterclockwise. And rocking means tilting the probe along the long axis. Next slide. For the abdominal exam, we're going to choose the curvilinear probe, but with the abdominal preset to maximize your image quality. You're going to adjust your depth to maximize image per body size, remembering that children have a variance in their body size as they age. It can be as little as 5 to 6 centimeters, all the way to 15 centimeters or so, as you can find in adults. And make sure for the gain, you maximize the image while minimizing the washout. So what that means is the fluid should appear hypercolor black, and the other organ structure should be visible but not too bright. Move forward to the next slide. So we'll start with the kidneys. Next slide. First, we'll focus on the right kidney. So to image this, we want to go to the mid-axillary line between the 9th and 11th ribs on the right, aiming the probe slightly posteriorly towards the spine. You want to ideally be able to fan through the entire kidney to get a good look at all the different structures present in the kidney. And what you should see in this image is the liver overlying the kidney in Morrison's pouch there. And Morrison's pouch is that thin white line separating the kidney from the liver. Next slide. All this is essentially mimicked on the left. It's just that now you're on the left side of the body, and instead of the liver, you have the spleen. This one is a little bit more challenging because the stomach is in the way, and so is the colon. You might get some gas. So you might have to angle the probe a bit more posteriorly to get a nice image of the left kidney. Next slide. So the anatomy you can be looking for in a normal kidney are the going clockwise around the kidney here, starting on the far left, the major calyces as in the center of the image, minor calyces just between the major calyces, the sinuses in between those, just abutting the calyx, the medullary pyramids a little bit higher, the cortex around the outside, and the renal pelvis into which all the urine drains. Next slide. And this is an image of fanning through the kidney anteriorly to posteriorly to make sure you get to all the different anatomy. So for this, we are using the tilting motion going along the short axis of the probe. Next slide. While we're here, we'll talk a little bit about the abnormalities, but mostly through the lens of normal. So it can be sometimes difficult to differentiate normal and grade 1 hydro because they look very similar. But the grading for hydro, as you can see from left to right, you should get progressive dilatation of the renal pelvis and thinning of the cortex. And the more you see, the higher the grade. You just kind of keep that in mind. Going to the next slide. Next for the bladder, next slide, we're going to be in the sub-umbilical region with the probe pointed into the pelvis, and you're going to want to look at both the transverse and the sagittal planes. Next slide. And if you can see here in this image, the bladder can sometimes hide pretty deep in the pelvis, so you'll need to rock the tail of the probe towards the patient's head to really get a good look at what's going on with the bladder. Next slide. So in the sagittal view, which is what the previous image was demonstrating, you will see the bladder on top. And then we've split this into male and female anatomy because there are different components we've been looking for. So the bladder is on top in both images, but on the left side, you see bowel gas, and then the uterus just to the right of the bowel gas, and the rectum just distal and right to the uterus. On the right-hand side, you see essentially the same thing, but instead of the uterus, you now have the prostate. And in this image, it's backwards if you are paying attention because the prostate and rectum are on the right-hand side of the image. Next slide. This is us fanning through the sagittal view of the bladder. This is going basically from patient left to patient right, making sure you can get all the anatomy so you don't miss anything going on in the patient's bladder from this view. The next slide, you're going from the transverse view, essentially doing all the same things, but now instead of that trigon shape, you now have a square shape to the bladder. So on the left for the female anatomy, the bladder overlying the uterus, which is overlying the rectum. And on the right, you have the bladder overlying the prostate, which is overlying the rectum. We move to the next slide. You can now see us fanning through the bladder, cephalad to caudad, to make sure nothing is going on in the bladder that needs to be addressed. For measuring bladder volume, you're going to want to take the maximum dimensions for the height, which is the left to right distance in the sagittal plane, and the depth, which is the top to bottom distance in the sagittal plane, and then the width, which is the left to right distance in the transverse plane. And then there are different literature values for the coefficients to estimate bladder volume. We will say split the difference here and say 0.6, to kind of get an estimate. Again, we're not trying to get an exact value. And if you're thinking about what's going on with this image, this is exactly when your nurses have a bladder scanner tool. This is what the bladder scanner automated tool is doing, measuring to get you that estimated bladder volume. And then next slide. And just briefly looking at urothelial jets, we don't do this very commonly, but if you ever need to, this is where they're located. So you want to put on color Doppler, looking at the posterior wall of the bladder, and you can see the urothelial jets entering on the right and left side of the image there. Next slide. And for those of you who are wondering, to make sure that the Foley is functioning properly, when you have a Foley inserted, this is what you should see that's considered a normal image. So you see that circle, the hyperechoic bright white line, the inferior margin, that is your Foley balloon that is fully inflated. You don't really see anything else around the Foley because the bladder is fully emptied and there's nothing left in the bladder but for what is in the water balloon for the Foley. Going for the next slide. And there's a little primer on female anatomy, which we don't really talk about male anatomy because it's not really in the abdominal cavity, but you can sometimes see these organs in our younger female patients, and which can have some contribution to pathology. So you're going to want to look at the ovaries using the bladder as your sonographic window. So for this patient, what we're seeing is in the transverse plane, we're using the probe to look through the bladder back towards the right ovary from the external left abdomen. So we go to the next slide. What you should be seeing is essentially this, the bladder overlying the endometrium, the myometrium. And this is more of the midline, so why you're not really seeing the ovary. But if we go over to the next slide, you can see in the sagittal plane, us looking at the right ovary, the uterus, and the overlying bladder, which we're using as our sonographic windows, is full of fluid to look at the ovary and the uterus. We actually see some follicles there on the right ovary as well. I'm going for the next slide. I'll pass it on to Dr. Dancel to continue our discussion about pathology.
So there's 17 of us. It's a small enough group that I would welcome if you unmute yourself and talk to us. That'd be great. If you don't want to talk to us, I'm also looking at the chat. So some of my cases are pretty simple and straightforward. Erin has a few that she would like to get some feedback from you all. I will say that GU ultrasound probably isn't the most exciting POCUS that we do, but for pediatrics, I use it quite a lot. And so this first case is just a very simple case of a 7-year-old kiddo with nephrotic syndrome. He was admitted for IV diuresis. He's on diuresis at home, wasn't really working for him. He had a Foley put in, which was working great, was getting pretty big doses of IV furosemide. And then on rounds one morning, you're rounding, and the nurse says, "You're not really peeing that much anymore." So there's a couple of possibilities here, right? Either we don't quite have our IV diuretic dose correct, or maybe we need to add metolazone, or maybe there's something wrong with the Foley. I think you know where this is going since this is a POCUS talk. So we'll go to the next slide. And this is what we're seeing in the transverse. This is one of the pocket ultrasounds, so it's a little bit overgained here, but this is a transverse bladder. And I don't think it's that hard to figure out what's going on. Anybody want to tell me?
I don't think the catheter is working.
Catheter is not working. So thanks, Andrea. How are you? So as Ajay showed, when there is a Foley in the bladder and it's doing its job, it really should not be surrounded by urine. So in a male, especially, you want to make sure that you get a transverse and a sagittal. Make sure that that balloon and the Foley aren't actually in the prostate. And here it doesn't really look like it is, but let's take a look at the sagittal. And here's your sagittal view. So you've got the Foley balloon and the end of the Foley really well placed within the bladder, which just isn't decompressing. So we had the nurse flush the catheter, and it's super satisfying to watch all of that urine drain out after you flush the catheter. And that's what happened. This is an issue that we see not frequently, but not as unfrequently as you would think. So the next case is a 5-year-old who is presenting with an unknown overdose. So he's sleepy, pretty much obtunded, and bradycardic. Blood pressures are okay. Doesn't really do anything to my physical exam, except for when I'm sort of palpating his bladder or his belly. He's sort of trying to push me away, so maybe a little bit responsive to painful stimuli. So I take a look at his bladder. And here's a sagittal shot of his bladder. So this is a pretty big probe that I have in my hand right now. And I am sliding from his pubic symphysis all the way up to his umbilicus. And then his transverse, nope, don't really have his transverse, but I've measured, I've given you some measurements here. And so I'm not going to make you do the math, and I'm not going to do the math online, I mean, with people watching me. So I did it previously, and it all comes out to be about 377, almost 400 milliliters, just depending on the fudge factor that you use, which, if you're talking about an adult, doesn't sound so bad. But does anybody know what the bladder capacity for a 5-year-old would be? This one may be hard.
We can call on people.
Well, I know of one person in this group has seen this before, but that's okay. So
It'd
the
be around 200, like 200, 220, somewhere in there.
yeah, thank you. The formula is age plus 2. And so he's 5 years old. So that would be 7. And that's the bladder capacity in ounces. So to get milliliters, you just multiply it by 30. And his bladder capacity is about 210. I think for those of us that are med peds, you think, okay, bladder volume of 300 something doesn't really sound as bad, but he really shouldn't have more than 210 in his bladder. So we're kind of scratching our heads. The only thing in his past medical history that he gets medication for, he's got ADHD, he's got an allergy for which he takes medicine. Unfortunately, he lives in sort of a rough neighborhood. And so mom is a little bit worried that he maybe got into some opioids. She said there's a bunch of meth, a lot of things that he could have gotten into. Any ideas, given sort of his presentation, what he could have taken?
Some THC gummies.
PH. It sounds like Travis has seen this before in his PICU. Maybe Benadryl. That's sort of what I was thinking too. Like what causes urinary retention this badly? I see a lot of Benadryl, and that's what I was thinking as well. And then he woke up and he told his parents where to find his bottle of guanfacine, which is his ADHD medication. And I've done some reading in the literature. I don't really see guanfacine doing a lot of urinary retention as a side effect, but apparently it is. This is a case of guanfacine overdose. He did fine after he woke up. And then this is my last case, which seems a little bit more uncommon, but I've seen it twice already. So this is a 10-year-old who's presenting with left-sided abdominal pain. 10-year-olds aren't really great with really localizing their pain or describing it super well. So that's all we had was left-sided abdominal, maybe some side pain. This was next slide is a transverse of his bladder. And I'm going to let it scroll a couple of times. This was so abnormal that I stared at it for probably a good few minutes before I could figure out what was going on or get close to what was going on. Anybody seeing anything abnormal going on in here? I'm trying to do the rule where I wait 10 seconds. What are the black circles? That's a really good pickup. So black circles that are sort of underneath the the bladder. So I'm going to actually have Finn go to the next slide and then we'll come back to this one. Sorry, Finn, there's a lot of back and forth. Okay, so remember this this slide that Ajay showed that tells us where the ureters come into the bladder. They enter the bladder in the trigone, which is posterior in the posterior wall, and you can see them sort of shooting up. So now that we go back to that transverse, I think now you may have an idea of what these black circles are. And so Finn is actually going to stop right where there is something that you can see in that black circle. And in fact, it's got some shadowing posterior to it. And we didn't talk much about artifacts. Yeah, that's correct. It is a stone. And I love that Julia actually picked up that there are black circles, plural, because there's one really big one on the right side of the screen. There's another one on the left side of the screen, which I think she picked up on. So remember, on the transverse view, things are sort of flipped. So the big circle on the right side of the screen is actually the left side of the body. And then there's a smaller one on the right side of the body. Let's look at a sagittal. And again, this was so abnormal. It took me a while to figure out what was going on. So if we pause right about here, Finn. Okay, I said, why is there a bladder on top of another bladder? And so what we're actually seeing here is a megaureter that is trying to come into the trigone of the bladder, but there's a big old stone that's blocking the way. So let's take a look at the kidneys. We'll look at the right one first. This is just a habit of mine. Okay. What do we think of this kidney? Yeah, that was sort of
Your hydronephrosis.
pretty severe hydronephrosis. You can't really see much of a cortex happening, and that sort of is the difference between severe hydronephrosis versus all of the other stages of hydronephrosis, is whether the cortex is starting to be effaced. So this is pretty bad. This is on the right side of the body. And if you think about it, there was a ureter that was sort of kind of struggling on the right side of that transverse bladder. But let's take a look at the left kidney. Yeah, that's like a double yikes. This is a huge, I don't even know that there's any normal parenchyma left behind in this kidney. But that's, if one of them was super severe, one of them was severe, this one is super severe. So I think the next thing I have is the CT scan. Yeah, so this is a CT scan, and you'll be able to see in this coronal, his two big old kidneys on both sides. Left looks worse than the right. And then as we follow the ureters down, really big megaureters on both sides. And so, like I said, this is the second time that I've seen this, but what's going on is that the ureters during development didn't insert into the bladder at an angle that would allow drainage of the kidneys. And so this 10-year-old has sort of been living with this for all of his life. And the stone was actually what brought him to attention, but the stone was actually an effect, not a cause of the hydronephrosis, but it's because there's so much urinary stasis. The other thing that I like about kids is he had his ureters explanted and then reimplanted, and his kidney function is fine. Both kidneys are working great. Couple quick normal variants that you might see in kids or in adults. You might say, what in the world's going on here? These are very subtle. The first one is called a junctional parenchymal defect. And you can see in the superior pole of the kidney, there's this little wedge-shaped scar-looking thing. And that's where the kidney, the ranunculi, sort of didn't come together and fuse completely normally. And so you have that sort of wedge-shaped defect. It has absolutely no clinical relevance in the kidney function. And then the other one is called a dromedary hump on the left kidney. You can see that the left kidney can be molded by the spleen so that it looks a little bit more triangular shaped rather than the bean-shaped right kidney. That's another variant. All right, Finn's turn.
All right. And I can't see the chat, so I still want you to type things in there, but Ria and Ajay, you have to shout them out because I'm not gonna be able to see them. So before I start, this is a reminder to me that none of these cases were actually my own cases. We have this great WhatsApp group text at UNC called the POCUS crew, where we have members from pediatrics, internal medicine, family medicine, emergency medicine, fellows, faculty, residents, and they will, whenever they see an interesting POCUS case, put it on that WhatsApp and then kind of teach us. And so I put credit to whoever took the images at the bottom of the screen, but that's just something that is really fun that we have, and I appreciate their work for these cases. So the first one is a 17-year-old with abdominal pain. I'm going to have a little bit more history than Ria had in hers, but this is a 17-year-old. She was recently diagnosed with chronic ITP about a month prior, and she came in with 5 days of worsening abdominal pain. She's sexually active, but she has started OCPs 2 months ago. She said she's taking them regularly, and her abdominal pain started pretty acutely 5 days earlier and then just got worse. Specifically today, got really, really bad. And she also syncopized 3 times in the past 24 hours. So that brought her to the emergency department. On exam, she's awake and alert. Her blood pressure is 100/60 and her heart rate's 125 beats per minute. So just with that history, is there anything that you all want to start with or anything that you're thinking about right off the bat?
We have one vote for torsion.
Okay. Great.
This is not a medicine thing, but sometimes I think about something like ectopic. I think those patients can be really sick and unstable.
Yeah. And I think it's definitely something that you should keep on the top of your differential for any young female patient or any female patient that is presenting with abdominal pain.
We have a vote for bleed as well.
What was it?
We have a vote for a bleed as well.
Bleed. Okay. So the emergency department initially, they were worried, could she be bleeding with this history of ITP? And so they wanted to look for free fluid in the abdomen. And so Ajay kind of walked through some of these before, but the probe in this case is towards the patient's head. This is a coronal view of that right upper quadrant. So I'll go through these a little bit more later, but feel free to put in the chat if you're seeing anything abnormal, just to orient you. This is the head, this is the feet. So this is the liver and the kidney there. And I'll go through these. We still have about 30 minutes, so I don't have to go too quickly.
We have one for lots of free fluid.
Yeah, so lots of free fluid. So they're going to keep looking at other places in the abdomen. They liked the thought that y'all had about, could there be something going on with the ovaries? So here is a transverse view. And on the left, we're going to fan through. And again, just throw out in the chat if you're if you're seeing anything abnormal or what you think could be going on. And I am going to go through these in a little bit. So don't feel bad if you're not sure. And then this is, I think that they just lit a little bit off to the right to get a little bit closer look. And then this is kind of a similar image, just maybe slid a little bit more over to the right side, or kind of focusing on the right a little bit more. Was there something in the chat?
Yeah, ovarian cyst rupture question mark from Emil.
All right, so differential so far, we've heard maybe a cyst rupture, maybe torsion, bleeding from something, ectopic pregnancy. So those are all great ideas. What labs do you guys want to start with? What's like one that can kind of narrow our differential relatively quickly?
Vote for a pregnancy test.
Yeah, great idea. And I don't have a lot of labs, but her hemoglobin was 3. So that was surprising. And then her platelets are 7, and then her beta-HCG was negative. So with that, we'll take ectopic off of our differential, and we'll go through this a little bit. So Ajay showed this before. Here's that bladder with the ovary and the uterus. So here's the bladder. And then this is actually this is the right ovary with a hemorrhagic cyst that had ruptured. So the black around there is free fluid. And so again, someone pointed out before, there's a lot of fluid there. So this is all blood. And then this is, again, that hemorrhagic cyst and probably some clotted blood around it also. So she went and got a CTA of the abdomen, which again showed all that blood. Initially on the CAT scan, they actually weren't sure what this was. So this is called a heterogeneous structure. But it also showed that there was active bleeding from the ovarian artery. So she went emergently to the OR, and they found 2 liters of blood in her belly. And then her right ovary had a 5 to 6 centimeter hemorrhagic cyst that had ruptured. So she underwent a right salpingo-oophorectomy with resolution of the bleeding, and then got a whole bunch of other things for her IVIG, or so for her ITP.
There's a question for you, Dr.
Yeah.
Finn. Does blood look different on fast versus simple fluid like ascites?
That's a great question. I think if it's acute bleeding, it can look pretty black and anechoic, so not necessarily. And you can see in this clip, really just looks like simple fluid. If you have layering or clotting of the blood, then it can look a little bit more hyperechoic. Sorry, I'm trying to play. Oh, this isn't a video, but I think in this clip, it's a little bit unclear, but probably there's some clotted blood here. So you can see that it's a little bit more hyperechoic, whereas the fresh acute bleeding is black.
I'm just curious, was there why they did a CT versus go straight to the OR with a hemoglobin of 3 and that much free fluid?
Yes, I think that's a great question. And I wasn't a part of the initial case, so I'm not entirely sure. They initially did not, there was a lot of back and forth about, they did not realize that like exactly what the cause was, if it was the source of bleeding was that ovarian cyst or not. So there was initial concern that there was bleeding from the spleen. And so she actually went to the OR with trauma surgery first when the pregnancy test had come back negative. So they said not ectopic pregnancy. And then they called OBGYN into the OR once they got this, once they saw the spleen was fine and that they had done this CT kind of on the way, I think, which showed the active bleeding from the ovarian artery. So that is my best guess. I don't know exactly the decision making there, but that seemed to be what the reasoning was. All right. Oh, and then I had put in, so this is from the POCUS Atlas, which is a great website to look at examples of different pathology. And so just since y'all mentioned this, your differential diagnosis here, this kind of scrolls through pretty quickly, but if you look, this is a sagittal view of the uterus, which you can see here. And then there's actually a fetus here. And so this is an ectopic pregnancy. And then on the right, this looks relatively similar to what we had. So this is also a ruptured hemorrhagic cyst. But you want to get that urine pregnancy test or the serum pregnancy, whichever you can get really quickly. And that'll help with your differential. Okay, so this is another case. This was also a girl presenting to the emergency department. Actually, all of these were presenting to the emergency department, but this is a 9-year-old who has 2 weeks of lower abdominal pain. And so just really brief history. This was progressive. She denied constipation, didn't have any nausea, vomiting, or fevers. She did note some difficulty urinating today, but then otherwise didn't have a fever, had normal vital signs. So just quickly, I know this is a pretty common complaint and not very differentiated at this point, but any additional history questions or anything you all want to do first? And I'm going to move this one along a little bit by just saying so the ED POCUS, quickly just to look at the appendix. Look, did someone say something in the chat?
It was Dr. Dancel
I
coming
just
on.
said this one is tough. This one is hard.
It keeps telling me when somebody puts something in the chat, but I can't look at it. So I'm like, am I ignoring things? But
So,
There was pain.
Emily's asking, is there pain or burning urination or pain in the back?
yes, some pain in the back, but kind of dull and not specific. And then she's having a little bit of difficulty urinating. So she doesn't say specifically that it's burning or anything like that. But I'll show you this. This is the ultrasound will help. So this, again, they were focusing because they were thinking maybe could be appendicitis, although she didn't have any fevers. But so pro marker, this is a sagittal view. The marker's towards the head. And I'm going to let it scroll through a few times, give you some more history and see what y'all are thinking, and then I'll go through it. So type in the chat if you're noticing or thinking through anything. Or if you have any other history questions that are coming up now that you're seeing this. It told me somebody had chatted something. Did you? There's nothing.
I'm waiting for Ajay to say it because I feel like I keep it. So Chan says imperforate hymen. Question mark.
Love it. So if you're thinking that, are there any other questions you want to ask?
Has she ever had her period?
She has not. All right. But her sister and mother had early menarche, and then she was noted to have some breast development starting a few years ago. So those are great questions. And that whoever said imperforate hymen, that is actually the diagnosis. So just to walk it through a little bit, because if you look at it initially, it's a little bit like what's going on. So you try to look at what you recognize that's normal. So here on the right side, this is our normal sagittal view. So you can see the bladder, and that's going to be this structure here. And then if the bladder's there, if you look closely, this is actually the uterus, and you can see the endometrial stripe there, which makes this the cervix. And this is the vagina, which typically we don't see very much of, because you can see on this view here, it's just kind of just a stripe basically. And that's all blood. So whoever was asking before about blood, you can see this blood has been there a little bit longer. So you have some layering and it's a little bit more hyperechoic than we were looking at before. Whereas this may be more acute blood there. So she was found to have hematoculpus secondary to imperforate hymen, and she went to the OR with GYN. Anything in the chat before I go on?
Nope, we were just complimenting them on that pickup.
Yeah, great job. Okay, this is our last case, and then we'll leave some time for questions. So this is a 15-year-old girl with seizures. So she was brought in by EMS after a witnessed tonic-clonic seizure. She's post-ictal and very confused upon arrival. So she's not providing any history, but her family's there and they say, well, she didn't have any fevers or headaches or any altered mental status leading up to this. Her medical history is notable for obesity, and on your exam, there's not all that much that you can really get, although she's hypertensive and tachycardic. So the ED provider, he wasn't sure what had caused the seizure, and so he wanted to just quickly perform a rush POCUS exam, given her tachycardia. And we don't have we don't have time to go through all of the RUSH protocol, but RUSH is rapid ultrasound in shock. And so you're going through your differential about different types of shock and trying to figure out what the most likely causes. And this is a POCUS protocol. And so he looked at the heart, which was normal. She had a collapsible IVC. She had normal lungs, no free fluid there, and also no signs of a pneumothorax. And then she had no free fluid in her right upper quadrant or left upper quadrant. And so then he got to her pelvis. He was looking for free fluid here. And y'all can shout out anything that you're noticing here, and I'll let it keep going. And for some reason it won't loop, but this is basically what you're seeing. Does anybody know what's going on?
Any NICU folks here?
You can just shout out what you see, like hyperechoic, hypoechoic, anything.
So it looks like a, if it is a bladder, it looks really round. And then there's like some, almost looks like septa inside of it. Like there's different echogenicities. I see that like posterior acoustic enhancement on the back wall. So it looks like a fluid filled structure. So I don't know if that's like a giant abscess or if it's like in the bladder and there's like weird stuff collected in there, like sediment or something.
Those are great thoughts. And this is, I'll tell you, you're not actually seeing the bladder very much here. So what else could we be looking at?
Could that be like a large bowel, like like colon expanded or full of stool?
That's a great thought too. So what other in the female, when we were walking through the female like pelvic region, when Ajay was fanning back and forth, what structures were we seeing? So we were seeing the bladder, and then what else?
Oh, it's a I just read Ria's comment. I feel like that gave it away. So
What was it? I can't see the comments.
Yeah, it said it's a mass of a sort. So I wonder if maybe I'm looking at the calvarium and not the it's not posterior acoustic enhancement, it's actually a skull bone from a baby.
Yup, you got it. And this is the brain. You guys see the
child. This is why I asked if there were any NICU folks out there, because they look at the brain so much.
Oh, that's true.
They'd have been like, it's like a brain.
Although Ria loves to look at newborn brains, and we've already looked at my newborns.
Mostly your baby's brains.
All right, great. So then what does she have then? Why is she seizing and hypertensive?
She's got eclampsia, preeclampsia.
Yeah, she's got eclampsia. So that as soon as they saw that, they were like, whoa, hold on. Treated her for eclampsia, and then she seized on her way to L&D again, and then had a healthy baby. And then that cured everything. When they asked her later, she did not know she was pregnant, and her parents were unaware that she was pregnant. And so those are our cases, and hopefully they were helpful to you. Just in summary, pediatric and adult POCUS is awesome. And I just listed some of the fun diagnoses that we went through with our cases, but can really change your differential diagnosis pretty quickly and is very useful. We had a few sources, including multiple colleagues, as I mentioned before. So thank you all for listening. We're happy to answer any questions or go back through any of the cases if you want us to. As I said before, we are all part of the Society of Hospital Medicine POCUS interest group, in addition to the Pediatric Hospital Medicine POCUS interest group. So we encourage you to join both of them if you're not already a member. So the left QR code here will help you join the SHM one, and the one on the right will help you join the PHM POCUS SIG. And then if you are interested in getting more training in POCUS, you can also look into the Society of Hospital Medicine Certificate of Completion, which the three of us have all done. And with that, thank you so much for your attention, and we are happy to answer any questions.
Thank you all for talking to us. It gets kind of lonely on this end.
It doesn't look like anyone has any questions. I think this was recorded. Right, Scott?
Yep, it was it was recorded, so we'll post it to the PHM POCUS YouTube channel, and then we can send out an email with a link to that too.
All right. Thank you guys. Thanks for inviting us to come today. We appreciate it.
Stay cool if you're on the East Coast.
Thank you guys so much. Yeah, awesome.
You
We'll
guys.
see you around.
See ya.